Welcome all. In the United States, a person born in 1900 could expect to live to 49. But by 2000, that person's great-grandchildren were likely to see their 77th birthdays. Reaching old age was no longer an anomaly. But around 2000, however, came a dramatic reversal of that trend, one documented by the husband and wife team of Ann Case and Angus Deaton. Much of the decline stemmed from higher rates of suicide, opioid overdoses, and alcohol-related illnesses, the so-called deaths of despair. Are these deaths the result of joblessness, increased poverty, or a breakdown in traditional support mechanisms rooted in family and community? Are individuals blaming themselves for their circumstances and feeling desperate and depressed? Is this a crisis of white Americans or racially and ethnically diverse groups also experiencing despair? And has the COVID-19 pandemic made everything worse? This evening, you and our audience will hear from a distinguished panel as they explore these complex issues surrounding suicide and addiction and offer policy and treatment solutions. We encourage you to join the conversation by using the Q&A button found at the bottom of your screen. We'll be taking questions about 45 minutes into this conversation, and feel free to jump in. In a moment, I'll introduce our panelists and we'll begin our discussion. But first, let me thank tonight's hosts, Columbia University's Department of Psychiatry and its Graduate School of Journalism. The Department of Psychiatry and School of Journalism have partnered to elevate this discussion of mental health and psychiatric illnesses, hoping to inform and engage citizens, journalists, health providers, public health leaders, and policymakers. This is the final panel in a series of 3, and we hope you'll join us for the winter-summer series that's currently being planned. Here are the 3, now meet the panelists. First, we have Oscar Jimenez-Solomon. He's a researcher whose work has the goal of informing multi-sectoral approaches that integrate mental health services and social interventions and policies to reduce financial hardship, psychiatric distress, and suicide. Since 2013, he has served as research scientist at the New York Center of Excellence for Cultural Competence at the New York State Psychiatric Institute, Columbia University Irving Medical Center. Dr. Christine Moutier knows the impact of suicide firsthand. After losing colleagues to suicide, she dedicated herself to fighting this leading cause of death. As a leader in the field of suicide prevention, she joined the AFSP as Chief Medical Officer in 2013. And it's through her passion and commitment that we see a lasting impact via research and education. You might have seen her on CNN and other cable news channels. She's a frequent on-air guest and quite an effective one. Dr. Sally Satell is a resident scholar at AI and the staff psychiatrist at a local methadone clinic in DC. Dr. Satell was an assistant professor of psychiatry at Yale University from 1988 to 1993 and remains a lecturer at Yale. She also recently did a stint at a methadone clinic in Ohio. I'm Jason Cherkis, your moderator, and I'm a journalist based in Washington, DC. I cover all these issues, and I'm currently working on a book about suicide. Now to the questions. First, I want to just throw this out first to Oscar. In their book, Case and Deaton say these deaths of despair particularly have been brutal on those without 4-year college degrees. It's not just economic instability that's the cause, because America's extreme income inequality, venture capitalism, and the decline of union jobs and the rise of contract work kind of can't be overlooked as contributing factors, they argue. I'm wondering, is this something that you've seen in your work play out anecdotally? And I'll let the other guests as well comment about that.
Yeah, thank you, Jason. And I appreciate the brief introduction to Case and Deaton's work. And I think just to help frame maybe the discussion, I thought maybe two more sentences about my read on their work may be helpful to also help contextualize my my comments about it. Maybe the 2 key things is that really what Case and Deaton observe is this change in mortality, and they focus especially. And they noticed this pattern among white, middle-aged individuals with high school or high school education or less, without a college degree. And you know, one of the explanations that they pursue is that perhaps the reason behind this increase in suicides and drug overdoses and in alcoholism and alcohol-related liver disease has to do with the overall economic dislocation and social fragmentation that this particular community has experienced over the last few decades. And the image that to me does it is in the book, an article they put it this way. They said, you know, a man born in the 1940s would be able to finish high school and be able to support a family and look forward to advancing economically, be part of a union and enter the union wage ladder. And what they see is that for every generation that has followed, there's been an economic decline that and really a decline in the ability for social mobility. So all of this to me makes sense, and certainly very consistent with the research that I know about and that we know about in terms of the economic factors for suicide specifically. I mean, this is more my area, so I'll maybe limit my comments to the economic factors of suicide, the economic determinants of suicide, and certainly much research on the impact of unemployment, increasing the risk for suicidal ideation and attempts, low income, but especially this concept of financial hardship, regardless of income, which is the experience of not being able to make ends meet, for example. Also increasing the risk for suicidal ideation, suicide attempt, and death by suicide. And we've been working on a literature review, reviewing the odds ratios and increased risk, et cetera, for suicide based on these economic factors. And one of the main areas that really rises to the top so far is unmanageable debts, the inability to repay one's debts, having too many debts, the size of the debts, and also the number of debts, and the inability, just plain inability to meet those debts. And so all of that makes sense. And maybe just to get started, the only two concepts that I think it'd be important that we, in our discussion, we continue discussing is this. One is that I don't think Case and Deaton intended for the conclusion to be made that the problem of deaths of despair, you know, this grouping of suicide deaths and alcohol and drug overdose related deaths, is only affecting middle-aged white men and women. I don't think they intended for that. I think they wanted to highlight the increased death rates for that subpopulation. But because when you look at when we look at the breakdown by race and ethnicity across age groups, the reality is much more complex. We do see that generally Blacks have higher mortality rates, and although there was a decrease up until the mid 2010s, 2010 or so, the mortality rate has plateaued, and for some age groups has actually started to increase, especially younger Black men and women. And I think that makes things a lot more complex. And the second notion that, you know, I'll come back to, and I'll stop for now, is this notion of despair. Despair conveys hopelessness, and the research on the mechanisms through which economic dislocation seems to impact, for example, suicide risk, does suggest that hopelessness is a factor, but it seems like there are other subjective factors, like, for example, financial shame, the shaming experience of living in poverty and dislocation. And the other big one is the experience of threat. Not only hopelessness experience of depression, but the experience of something bad's going to happen. There's some really important and growing research in Europe and in Canada that have pointed out that this experience of feeling threatened by economic dislocation is a big risk factor. And I think when when we think about solutions, interventions, and policies, we probably really need to better unpack what this despair means and to better understand the mechanisms and to also think about solutions, both in terms of addressing the objective aspects of economic determinants, but also the subjective ones.
Sally, real quick, did you see these kinds of issues pop up in the clients that you were seeing at the methadone clinic, the people that showed up were in recovery, but was that in their background? There's issues of debt, financial instability, housing instability. Were they playing out? Were you seeing that on the ground in Ohio when you were there?
Yeah, let me just orient a little bit about what I did. It was a town called Ironton, Ohio. And if anyone's familiar with that area, it's a very tip of Ohio. It's called the Appalachian Rust Belt. So it's not deep Appalachia, but it's not Cleveland or farther north. And so it's right on the border of Kentucky and West Virginia. And so I thought that Oscar gave, an excellent foundation for what I really did see in microcosm. So I won't repeat everything, all the factors that he enumerated, but I will add that I think what's especially pernicious is the or I should say, I guess, intergenerational dimension that the patients I saw, and for what it's worth, it wasn't the methadone clinics in DC. Yeah, no, that's fine. This was a substance abuse clinic. In fact, this little town, most little towns don't have, it's 10,000 people. That's not the littlest, but it's still small. They don't have their own methadone clinic, but they had buprenorphine clinics, and you could go to methadone in those Ashland, Kentucky, or Huntington, West Virginia, which were within 20 miles of most people. So, but in any case, it was the fact that not only did everyone as a group have all of those factors, perhaps not every individual did, but as a collective, they touched on everything Oscar mentioned, but that their mom had that experience and their grandparents had that experience. And that was consistent with the fairly recent history of this town, which is to say that, its heyday was actually up until World War I. It may, as the name implied, it made iron. It was definitely, I think, the national leader in pig iron production, and had done well with every war subsequently, because there's always a need for iron-based materials. But it had been, kind of declining since maybe since 1925, but managing for sure. And up until but in the late 60s, the big industry, a few of the big employers started to go under. And these are towns where everyone's pretty much employed. In this case, not one major employer, but a few major ones. And then, so those left, and then it was a domino effect through the 80s. The town was bankrupt, and on and on and on. So there were many decades for these dynamics to play out and entrench themselves.
And just to piggyback on what Oscar said before, Christine, how would you define despair as you see it?
Well, I see it as part of the human experience. Honestly, these are factors that relate to human health, life that is unpredictable, and as much as we as human beings need social connection and crave a sense of control and the ability to plan for our lives, we are in a setup that will involve constant struggle for many of us. Most of us, or all of us at different times, let's put it that way. And so I think the extent to which somebody becomes more hopeless, where their own internal dialogue intersects with those human experiences of disillusionment and unmet expectations, despair. I think cultural factors have to do with this as well. So, for me, the deaths of despair construct is a human kind of global thing. And I think Case and Deaton described a sub-phenomenon. I like the way you put it, Oscar, that yes, this is true and very important, but it does not speak to the larger picture of overall trends in suicide. Suicide is more, much more my expertise than addiction. But so in some ways, I think the media surrounding the Case and Deaton work became sort of a different way of understanding the larger picture. It sort of got generalized into this issue of economics and education and race that are clearly important to look at and to understand and try to understand what the implications are as a society and for policy. But we shouldn't stop there, and we can't stop there. We actually need to look at each phenomenon of suicide specifically, and addiction, and the other trends geographically. And we need to look at experiences of health disparity, economic disparity, educational disparity, and where issues of, again, geography and race and other forms of identity intersect with those. So it's just, I guess, all to say that that this is complicated, and we're going to get into like little streams of conversation about certain topics. But I just want to have an awareness that when it comes to, at least again, suicide prevention being my area, we can't get stuck on just one prong of the multi-pronged approach that will be necessary to actually reverse this trend and drive down suicide rates. So
you're thinking that in order to address the deaths of despair, we have to do more than just look at just suicide or just economics or just the opioid epidemic or big pharma, those kinds of things.
Yeah, most certainly that. And also, in a way, I was starting with, in a way, the converse, that the deaths of despair story became generalized in a way that I think kind of took over the media cycle for a while, that then was not adequately looking at the trends in, for example, Black youth suicide and Latina adolescent suicide attempts, and the increases in, among educated populations, physician populations, other sectors where there are also concerning trends.
That's great. I saw you nodding along. Do you have something to add about that? I mean, there's definitely this rise you see in Black children suicide deaths. Latinx teens have very high rates of attempts. A lot of that is also tied to the same factors that Case and Deaton point out. This sort of huge instability, crushing economic impact, economic problems, those kinds of things. Oscar, can you speak a little bit about that?
Yeah, no, I mean, I just want to echo what I'm hearing from Christine. One way that I would describe it is that I think this is an invitation. This conversation and maybe the work of Case and Deaton and the entire notion of deaths of despair is an invitation for all of us to rethink the paradigms that we've been actually working with to approach suicide prevention and also perhaps addiction treatment and recovery. As it relates to suicide prevention, there's actually a very interesting, very important review from like 2 or 3 years ago. That it was meta-analysis, big study of 360 longitudinal studies that assess risk for suicide. And it is true that suicide attempts are on the top 5 predictors of death by suicide, but so is low socioeconomic status, and the difference is marginal. And what it's done by Franklin and colleagues is a very important meta-analysis. And I guess the main reason why we're going to bring this up is because one of the things that they highlight is exactly what I think I'm hearing from Christine, which is that this battle of picking one risk factor against the other is a losing proposition. And what this really calls for is an effort to create multi-pronged, multi-level, more complex interventions that can tackle the clinical risk factors and also some of the other contextual factors that we know about, whether it's geography, socioeconomic status, social fragmentation at the more community level. And this is the part that we don't have. Now, as it relates to racial ethnic disparities, yeah, I mean, I'll just say a couple more things that I already heard from Christine. The last few years, there have been several studies that have pointed to, for example, the increase in, we all know that suicide among adolescents, 15 to 19, has actually increased for all groups. But the most dramatic increase has actually been among Black teenagers, Black teenage girls. And the increase has been in about 3.5 times in between, just looking at the numbers right now, it's actually between 2007 and 2017, the increase in the suicide rates among Black teenage girls went from 1.2 to 4 per 100,000. Still much lower than other groups, but the magnitude of the increase has been really significant. Among Black children under 13, looking at data from between 2000 and 2017, Black children, their risk has actually increased to the point where it's actually twice as large among Black children, twice as large as white children. And the list goes on, you know, and but something else that I just wanted to mention is that death is an indicator that is really important. Ultimately, we want to prevent is death, but that's really a symptom of a larger problem. And when we look at other indicators besides death, like for example, ER visits in New York State, the data that we have shows that that there are very significant disparities in the adult population when it comes to self-injury related ER visits, where African Americans, especially in New York City, but also outside of New York City, have almost twice the level of psychiatric visits because of self-injury. And the last thing I'll mention about this is that, which is really significant and important, is the question of the why. And certainly the economic aspect is important, but during the last decade plus, there has been significant progress in observing the impact that other important factors that affect the Black community that are becoming documented risk factors for not only depression, but also suicide. And I'm speaking specifically about racial discrimination. Perceived racial discrimination, now there are several meta-analyses and systematic reviews, the evidence is strong, suggesting that racial discrimination has a negative impact on health outcomes in general, and especially around mental health. And several studies have documented the increased odds of suicidal ideation and suicide attempt, both among adults and also among adolescents, when it comes to, because of racial discrimination. And there are several indicators that start suggesting causality, like for example, this gradient where there is a dose response effect in terms of racial discrimination and risk for suicide. The temporality, several longitudinal studies that actually have shown that experiencing racial discrimination at point A predicts the onset of suicidal ideation and attempts in point B. This is an area that is important, and with everything that's been happening and all the conversations we've had this year, I think it's important that we introduce that factor in the discussion of how also mental health systems, collectively, we have the responsibility to address and buffer the impact that racial discrimination in tandem with economic dislocation have in increasing the risk for suicide and other mental health conditions and mortality.
Sally, you want to say something?
Yeah, I do, thanks. I think sometimes the family is left out of this discussion. And I mean, we're talking largely about, outside forces. And when I mentioned before that one thing that was so characteristic of the folks that were in our clinic, and it's so smart in a way to have suicide and addiction the same discussion, because I do see both as an expression of something far more subterranean, which is exactly what we're talking about. But when I mentioned that, they all had, almost all could point to parents and grandparents, who were similarly, struggling with drugs. That wasn't a sort of a static observation. I mean, this is a dynamic. The farther down in the generational pathway you get, the more the family dynamics unravel. I mean, if your dad loses a job and everything is otherwise stable and there's a good foundation in the family, chances are, he could turn to drinking or using drugs, and it would be very problematic for the family, but the foundation is stronger. But as time goes on, that instability worsens, and when you're a kid growing up in those kinds of households, you don't learn emotional and impulse regulation very well. Attachments don't form as strongly as they can. People's self-worth really is eroded. And it's one thing to erode, I should say. Sometimes it's never really even formed in a healthy way. And these are also vulnerabilities that add to what's already clearly a very complex picture. But I think I get the feeling sometimes, maybe it's safer to talk about that actually in white culture sometimes than it is in others. But
Isn't that one of the issues with mental health care and addiction care? And often the family is separate from the treatment. A person goes into a 28-day facility. They're told parents have to stay away. They're not really into it. I've interviewed many parents who, when they're basically clueless when the kid gets out of care. They don't know what to do after that. And that's where the problem really happens, where relapse and maybe fatal overdoses can occur. They're often sort of separate instead of joining them together. There was a methadone clinic in Massachusetts that made a point of bringing in the parents or a family or a friend or a peer right at the first day, keying them in, watching them through the process. And we've seen suicide research. There's great work by Cheryl King up at University of Michigan with what's called youth support teams, where a teen comes into the hospital after making an attempt. They have to nominate 4 or 3 people in their lives that they can sort of call on. And those people will be trained in basic mental health understanding. I mean, what we have here is a lack of understanding among all the different groups, the different family members. No matter what happens with the family, they're going to be coming back to them. And so you see, we just training people to be better at understanding mental health or understanding addiction can go a long way. Christine, can you speak to that? Also, Sally, you brought up just a really good point about history, family history. There's also the history of mental health systems and addiction, and the sort of myths around them, and the myths around mental health and around being stuck in an institution. And people are really afraid to engage in these systems because maybe there's some punitive elements. There are punitive elements to them. And so I think I had interviewed a kid, a young Latinx teen in Baltimore, and she was hospitalized, and her father said to her during their first visitation, "You're a coward because you didn't succeed in this, and you brought shame to the family, and you're here." And that was not an unusual thing for me to hear in my reporting, but maybe Christine, you can speak to the family dynamic, peer, and just sort of the history of that maybe we're coming up against.
Yeah, I mean, this conversation is just making me think about so many things, and the role of the family. We love our family members. We as parents love our kids. We as kids love our parents, and yet there's been something in our cultural drift or evolution of late in recent decades that, despite, for example, data that says that the public is opening up and becoming much more progressive, at least about the idea of mental health being real and valid and significant, it has not yet led to people having that actionable knowledge about what it means in the way that I'm interacting with my loved ones in the home. And I will say that that's one sort of critical but microcosm of this larger society that was built without any knowledge about the brain, about the need to stay connected. We actually, I think, as a more progressive, civilized, technologically advanced society, thought that those primitive societies, and cultures, were somehow less advanced. And the truth is, the relational social connections that remain true in many, less evolved, developed areas of the world, that's a protective factor that we somehow didn't incorporate into the advancement of our societal evolution. And I just think about the many ways that even, for example, another just piecemeal example of this, we built a system of response to mental health crises around a punitive assumption that discipline was necessary to respond to, behavioral. Even the word behavioral implies willful. These are issues of health. And I think the reform that we will need to see now, and with the passing of the 988 Suicide Prevention Hotline Designation Act, we actually have an opportunity to do more than just a rebrand of the name of that. We can actually fund and revamp and resource communities so that there are trained people. They could be trained peers, they could be mental health practitioners, they could be a whole variety, but not what we had built previously, which was essentially a law enforcement response to a health crisis moment. And then you build in the racial discrimination history and unconscious bias, and you have a real setup for especially certain populations feeling like they will avoid not only medical care at all costs, but they will not tap into those crisis systems for fear of the treatments that we've heard about of anyone, but particularly if you're a person of color. And so, it's almost like we're sort of realizing that with the advancement of science and neuroscience and all of the disciplines that are informing what leads to risk and despair, back to the deaths of despair, we're going to have to rethink and reform several major systems that we have, and that's going to take policy work for sure.
Well, and funding too. I mean, if you want to revamp the hotline, everyone knows that follow-up phone calls work, that reaching out beyond those single calls is really, really helpful, but there's just isn't a lot of money in certain areas for those things. Oscar, can you speak to some of the issues we're talking about? I think one thing that I just sort of was thinking about while you guys were talking was just peer support is really kind of coming up into its own as a thing, as an idea of having, we see that in the early days of AA peer support and its success. But we also are starting to see that in mental health care. There's a great program out in Seattle where somebody who comes into care is assigned a peer who's been through it before, and they help them through their hospitalization, and then for the next 3 months out of hospitalization, they're with them to navigate them through, getting that first prescription, going to the first therapy appointment, and just being there, getting them a cell phone, whatever it takes. It seemed like a cool idea.
Yeah, no, thanks, Jason. Maybe I'll just wanted to say I very much echo what I'm hearing from Christine, and I connected to peer support, and I'll go into that in a second. There's this concept that to me helps understand maybe part of the work that we need to do collectively in mental health, and especially in suicide prevention, and is the fact, I think, that we've medicalized and perhaps over medicalized and psychiatricized. Some people made it a verb, actually. A condition that is a lot more complex than just a medical condition, that has so many other components and factors of social dynamics that to be able to understand it, and also to be able to tackle it more effectively, part of our collective work, I think, in public mental health, perhaps, is to actually also shift the way that we understand suicide, but also just mental illness in general. But I think part of that is actually thinking about these other interventions that can actually help, right? And I think you're bringing up the question of peer support, and certainly peer support during the last 3 decades, there has been growing evidence about its feasibility and its effectiveness around different areas. The overall evidence is strongest around hope and empowerment. It's a little shaky in other areas, and in part because a lot of the studies around peer support are conducted in different circumstances. But one of the things that we do know is that there's very strong evidence that peer support is can be helpful in building a sense of hope among the people that actually participate in peer support, and an overall sense of empowerment, agency, which are really key protective factors for suicide and also recovery and mental health in general. And maybe I'll just finish with this. Within the last year, there was, to my knowledge, is the first randomized controlled trial that has actually tested the initial efficacy of a peer-led suicide prevention program, and has very promising results. And there is a growing workforce, as probably most of you know, of peer providers. I think there are questions still about what is the kind of support, training, supervision that, and how do they merge? How does peer support work in tandem with clinical services? I think that's a question that still we need to work on, is how to do that effectively.
Sally, did you have something to say?
I was just going to say, Jason, I think things are getting better. Not that they're there for sure, but in terms of this appreciation of the need to embed somebody in this, a larger system of support, because as folks have said, the connection is so important in terms of just demonstrating things that I think we all so many of us take for granted, that someone else has some faith in you and they're willing to, devote that time, and that that other person is like a model of reliability, because they show up and drag you out of your house when you don't want to go. And that's a structure in your life. And I think when people probably, when they're in the penumbra of a suicide attempt, and certainly when they're trying to get out of addiction, they don't know how to do, everything that's the slightest bit of effort is something that's easy to dismiss. And when you're with somebody who can kind of hold your hand and show you how to do it and half make you do it, just like getting a driver's license, an ID. So many people that we see just don't even have an ID. If you don't have an ID, then you can't get a mailbox, and you can't do a million practical things that make you feel like you're, more grounded in the world. So anyway, I do see that as getting a bit better. And I agree 100% with what Oscar says about the medicalization. I think that is one of several forces that has led to the extent that we don't see enough of this, these mechanisms and that try to put people in a larger context. That is one of the consequences of medicalizing some of these very complex phenomena.
Well, I mean, Sally, in a recent article that you wrote,
that was my segue.
Yeah. You wrote that, you're really arguing against this notion that addiction is a brain disease. And you write, people who are addicted can respond to carrots and sticks, incentives and sanctions. And I'm wondering how this has worked, and you're really kind of arguing against it's, just to push back a little, NIDA, WHO, SAMHSA, the American Society of Addiction Medicine, they all use these terms. I personally think that calling it a brain disease is effective, at least in terms of helping people understand. I've never interviewed any scientist in addiction who says it's the end all be all, the only piece of the pie. There's other factors that you bring up, environmental and those kinds of things, genetic, and just sort of access to the drugs. But can you speak a little bit to that, the idea that it's not really a disease?
Well, there are two things. There's disease and there's brain disease, and I do see them as quite different rhetorically. But I've had that largely the same observation, is that when you talk to people who are really in the you get their hands dirty in clinical work, or sometimes a little bit less so in research, but also researchers as well, is they will certainly acknowledge that there are many other important dimensions, but the reason why I find why I've been speaking out for quite a while about thinking a little bit, realizing how oversimplified a brain disease model is, and that's my main objection, is it doesn't do justice to addiction. It's much more complicated than that, is simply because the leadership at NIDA has made such a big deal of that. They're always, using brain scans to illustrate that it's a disease, and that is kind of the visualization technique. If you're going to promote a very reductionist model, nothing wrong. The brain scans are true. I mean, I'm not arguing that addiction affects the brain, more that it's a extremely complicated phenomenon, and that you can think about it in terms of neurobiology, but that's just one level of explanation. And there are so many others. There's psychological, there's environmental. That's pretty much what we've been talking a lot about before. Just that there are so many that we want to, and they're not mutually exclusive, although I do think that some are more relevant in some patients or people than in others, and also in the same person over time. I mean, for example, you can have someone, counselors tend to poo-poo what's called the geographical cure. If I move somewhere else, I'll be fine. Well, you know what? For a lot of people, that works darn well. They remove themselves from their old social networks, the ones that are being destructive to them, unfortunately. They remove themselves from all the cues that stimulate craving. And then you can get the neuroscientist to tell you all about the craving cascade. It's very real. We're not arguing about that for a moment, but it's in this larger context. And anyway, so in a person like that, for example, the geographical cure is not simply the person relocating, but the fact that there are so many attendant factors that change during the relocation that they are able to change their behavior. And the addiction is fundamentally a behavior, because you wouldn't call anyone an addict unless.
Aside from like the Vietnam example, are there other examples where it's actually been studied where people moved? Like, has that been proven other than Vietnam, which everyone brings up? Oh, Vietnam.
Oh, of course, I've seen that. Oh yeah, I hear that story all the time. I didn't stop.
There's a difference between that story and that study. So there's a difference between that story and that study. Like, I understand, like, anecdotally people say, oh, I moved away and I didn't see my bad drug dealer friends, but there's also the idea of studying this. And like, is there a study that you can point to that shows that, like,
yes, we can put up a list after this of all the sociological examinations of addiction. And in fact, that's where we often should be looking more if we want to affect. This is the deaths of despair. This is the domain in which the deaths of despair reside. It's in sociology, actually. Anyway, but that's my main, that's why I always sort of bristle when I hear that addiction is a brain disease. Although if that helps them, that's fine. I just want them, as long as people realize that a drug, buprenorphine and methadone, which clearly I endorse, I work in those clinics, but I have rarely met a patient, and there are a few, but rarely met folks where that's enough. It stabilizes people. And certainly that is the first step. You have to stand still if you're going to repair your life. And these medications are, for some people, just completely essential to that. But then there's so much other work to do. And again, my concern is that a highly medicalized view puts too much emphasis on medication, as if that's enough. So I would say it's necessary for many, but rarely sufficient. And remember, most people get clean on their own. They do not come to a clinic.
Sure. I understand. I guess this is pointing to my last question here, which is just very simple. It does feel like there's a lot we don't know. And I'm wondering, like, for each of you, what is one area that you want to investigate more, that you think needs to be investigated more in terms of how we can address deaths of despair, or how we can figure out better to predict suicide or help somebody who is in the throes of an opioid addiction?
I would like to see more collaborative research between disciplines so that we could, right now, a lot of the interactivity between these spheres of biological, let's say genetic, psychosocial, early trauma, current environmental, economic, health access are kind of in their own silos. And so they're informative, but they just tell one piece of the puzzle. And I think we need to start doing something that's a bit more integrative, certainly starting with substance use and suicide. I mean, that has been a bizarrely siloed kind of, streams running. And we know there is so much interaction in probably multiple ways, way beyond just the fact that many overdoses cannot be detected, but were likely intentional deaths. But way beyond that, so I think that's where we're very early as a sort of scientific field is doing more collaboration. It's hard to do. It's hard to get funding for a very elegant, simple study, let alone something where you're trying to coordinate, multiple departments and disciplines.
Oscar?
Yeah, I couldn't agree more with Christine. I feel like I've been experienced at a very personal level because I've been, I'm trying to do this research that integrates this economic aspects and also the clinical ones, and it's a challenge, right? Because it means both better understanding the economic factors and getting more training in that area, and also the dialogue with the clinical side of things. We're working right now on a pilot for an intervention that is trying to tackle all of these at the micro level. It's a peer-led intervention to address financial hardship and suicide risk. And there's some very concrete components to it, like, for example, helping people access financial counseling and tax credits, and those very concrete services that could relieve some of the financial hardship, like debt, for example, and managing debts, right? But then also the peer support component, which is important to buffer the subjective, how people are feeling about their financial life. And at the same time, to be able to make sure that their clinical care is strong, because it's important as well if they actually are at risk of suicide. So really working all those pieces together to really try to operationalize in a very concrete way an intervention or set of interventions that can really tackle more than one factor at a time is certainly a big challenge. So I think that's the work for us, in the next generation of studies. And I think part of that is also thinking very concretely, not only understanding, I see the value in better understanding the impact through natural experiments, because I think it's really important that we not only understand in the abstract, let's say, what the impact of employment or unemployment or poverty or hardship is, but also what happens when we introduce certain interventions. And we were chatting about this in prep for this call, that we know, for example, that there are some social interventions and social policies that at the collective seem to have an impact. Like, for example, states that have more generous earned income tax credits see over time a reduction in suicide. States that increase their minimum wage, the same. States that and countries that have more generous unemployment benefits are able to buffer, for example, the impact of recessions on suicide. Housing, eviction protection programs, and the like seem to also have promise in buffering some of the impact, because we know that housing foreclosures, for example, is a big risk factor, increases their suicide rates at the community level. But what we don't really understand well is how to integrate those kinds of interventions with clinical care. And I think that's actually the part of the work. And And I think to begin, I mean, I'm just trying to share maybe a couple of ideas of the kinds of things that could be done while we learn more about it. I think that there are some very concrete strategies that local programs, clinics, and counties and states could work on to really be able to create that collaboration also in terms of intervention, like partnerships between mental health clinics and supported employment programs, for example, or local financial counseling agencies that can help people with two ends. One is to both be able to refer people who are experiencing a risk of suicide, depressed, or experiencing a higher risk of suicide or prior with history of previous suicide attempts, who are also experiencing financial hardship, to be able to have a very warm handoff to so that people can get help with their very concrete financial situation, but also the other way around, that there are many people in the community who are being touched by those financial programs, but that never make it to the mental health system. So we could actually establish stronger partnerships so that people that go to unemployment offices, that are in touch with the Department of Labor or financial counselor or bankruptcy courts, and a number of other touch points where people are really in distress, eviction, et cetera. And they could actually be perhaps referred and receive the clinical care that they need. And I think how to do that, we don't really understand it really well, but and I think that's where the research should be in the years to come.
Sally, what do you think?
Well, I think what Oscar said is so fascinating. And one of the questions that I would wonder about is, honestly, for some percentage of people, if you could affect all those interventions, I don't even think you would need mental health intervention. But the idea, if mental health is the kind of the way they get into, they come to attention, if our system could make those connections, it would be incredible. Anyway, I'll be brief because now you only have 10 minutes for Q&A, right? Which is, I would like to see more research in what's called contingency management in addiction, especially because with methamphetamine now being very ascendant, or stimulant drugs, we don't have any methadone or buprenorphine or naltrexone or anything like that. And you have to rely on clinically, one of the most promising interventions are the way to, the best ways to align incentives and what are the nature of those incentives. So that's what I would vote for.
It seems like the key word is integration, is stepping out of these different silos. And I mean, this has been a goal for a long time. I was reading some of the earliest books on suicide research, the goal being understanding that there's all these different ways that lead to a suicide. It's not one thing. And by integrating it, it's really such a great idea. There's some of these ideas what I'm hearing. We're starting to get some questions, some real sharp fastballs here, guys. So get ready. What role do you believe the lack of purpose and meaning has on deaths of despairs? And maybe in the sort of the increase in secularization in the country.
Yeah, huge, right? I mean, I've been thinking about Viktor Frankl's Man's Search for Meaning during COVID. One of my favorite all-time books, and really kind of gravitating back towards that basic construct that if a person has a sense of meaning and purpose, almost no matter what they're going through, they can stay with forward movement and connection to that. And our resilience capacity is humongous as human beings if other things are remaining strong. So I do think that's huge. But I do think not only external circumstances, kind of get in the way of that, but our own internal stuff does too. And that's where the complexity comes from, is it's interactive. I do see mental health conditions as being part of human health conditions that are very multifaceted, but will continue to be present in our human existence. Unfortunately, even if we create a utopic society, we will still have to deal with issues of human health and mental health.
Sally, you were going to jump in?
No, I think you want to get through. We have to.
Oh, okay.
I don't know.
Another great point. The same person had another great point, which was just Given the heterogeneity of various subgroups, how do we avoid one-size-fits-all and top-down approaches and understandings, which may not take into account the individual differences among people who take their own life? That's tricky.
I think we have to conduct our actual organizational and professional relationships in a truly collaborative way. I mean, I will just say that many academic institutions, including Columbia, also the way that AFSP is organized, where we've got chapters, boots on the ground. So these are volunteers who have their day job is in all sorts of different fields, and they've developed relationships with schools, corporate workplaces, law enforcement, policymakers. And so it's very organic, and yet there's forward movement because of that development of trust and shared learning back and forth, rather than an expert coming in. That model can obviously work for some things, but when it comes to suicide, we have to build a safety net that's very multifaceted.
Maybe I would just go back to this notion of integration and stepping outside of our traditional understanding of what mental health program or suicide prevention is, to be able to integrate the myriad of needs that people might have, right? Because if we actually have a system that is truly connected with the support that people may need to address the multiple stressors that they might have, whether it is poverty or financial hardship, or discrimination and trauma, or some other clinical needs, right? We'd be able to respond more, I think, effectively to those individualized needs. And I think part of that really it goes through maybe changing a little bit of our understanding of what are modifiable factors. I think we have worked typically with the understanding that there are certain factors that are not clinical that we cannot affect. And I think that may not be the case if we actually may not be necessarily the case if we're able to create a broader tent where we have we integrate supports of different type to be able to tailor and support people more individually.
Well, I mean, well, one of the ideas is just something that Victor Patel has told me up at Harvard, which is pretty simple. Vikram Patel up at Harvard said, when you're creating a therapy, you want to see how scalable it can be. That should be the goal. Can we give it to the most people and affect the most people? And a lot of interventions that we've seen created, maybe more so in the 70s and 80s, super complicated, pretty expensive. Not everyone's trained in it. Can't treat that many people. And what if we flipped it and we said, let's create a therapy where we can scale it up super fast and we can give it to many people and it's effective and we've tested it. That sort of seems like a worthy goal. Just something that I think people are sort of shooting for. Christine, you're smiling. Am I talking like kind of crazy? Am
No,
I not too smart?
It's tough because the development of specific suicide risk reducing treatments has required a different approach that moved away from the idea that if we just treat depression and psychiatric illness, we're going to see this beautiful byproduct of suicide rates coming down. And to a certain extent, there is a relationship, obviously, between illness-induced brain states that do change one's interpretation of hope and worthlessness and things like that. But the reason I was smiling is I was thinking about, on the one hand, we need to scale up access to CBT, DBT, different family therapies, peer support models that are showing promise for suicide risk reduction. And on the other hand, we haven't even yet taught each other how to approach the conversation to allow people to talk about their suicidal experiences and their states of desperation. Right now, people are mostly zipped up around that. And that's part of the movement of suicide prevention that's so exciting, is just simply giving people the language and the skills to support and unconditionally love each other, even if they're struggling. And the truth is, everybody, we all face struggles. So that's the part that I feel like that ability to connect and take stigma out of the equation to every extent possible, that is powerful. And so that is a very universal approach that can be taught, in any setting.
That's a great point. Just for many people, they're afraid to they'll maybe show up at a therapist's office, but maybe they won't talk about it. They won't admit to it. It's really easy to deny suicidal thoughts.
Oh,
And
for sure.
making it open, telegraphing that it's okay to talk about it, that encourage it, to not stigmatize it. That's something that you're right, we are really behind on.
In a treatment setting, but I'm talking about even in your home, in your, social friend groups, in your place of worship. If we're gonna have deeper, authentic relationships, these shouldn't be off the table. But we do have to teach people how to respond in a way that's constructive and not, harmful to the person.
Jason, can I ask a question?
Go for it.
This is Jeffrey Lieberman. I agree, completely with all the comments that Christine and Oscar and Sally were making about the multifaceted nature of the factors that sort of contribute to the disaffection and the pathologies that permeate certain regions like the one Sally was in. But the title of the paper and the book and the forum tonight was on despair, sort of some grouping rubric that encompassed these various, causal factors. And, it's been alluded to in other ways, like some kind of spiritual sickness or vacuum or so forth. And so, there are these individual factors, whether it's unemployment, whether it's addiction, whether it's, domestic violence, that sort of contribute to these, but they're exacerbated or they're reified by this sort of larger dynamic. And I was wondering, if that's a valid construct or interpretation, but beyond that, if there's anything to be learned or any parallels to what might be called sort of these populations that seem to be, particularly severely affected, like Native Americans or Aboriginal cultures, which have had, huge rates of pathologies that have, have roiled their populations, and whether this is sort of a model of what's facing us if we don't do something.
In those examples you just gave, there's obviously historical generational trauma, and that cannot be separated from the perspective on, suffering, distress, suicide rates, addiction. But I do wonder about, for example, groups that had the opposite, who traditionally have had lower rates of suicide, and where we see those groups trending upward. Then I do really look around for the research about what is changing in either the cultural layer, the social integration, basic things like where are the hubs of those society, who are the trusted individuals, from hair salons to places of worship to ways of congregating as communities, and are those shifting in some way? The things that may have been protective, we may be moving in the wrong direction in certain communities.
Got two questions here. First, from Meg, just to comment, as someone who has lost a brother and sister to suicide, and this brings up what Sally's point really early in the conversation about generational issues. I've lost a brother and sister to suicide. We need to figure out a way to provide information, comfort, and a voice for the family members who suffer on the sidelines. This has certainly been a cause in suicide prevention circles for quite some time.
And I should just quickly mention before my colleagues chime in on this, that the Saturday before Thanksgiving each year is a day that Senator Harry Reid, who lost his father to suicide, made a national, and now at AFSP we've turned it into an international day for survivors of suicide loss. And there are events that go on, there are resources, and more importantly than anything else, it's a way to meet other loss survivors and connect to a community where you can share resources and just have relationship, actually. So it's, I'm so sorry for her losses, especially multiple in her family. And I hope that she's finding ways to kind of move through that grief and loss.
Sally, Oscar, do you want to chime in at all?
I agree.
Oscar, I'm putting you on the spot. Okay.
No,
yeah.
I do too. I mean, the only thing I would say is that maybe following up on our conversation, a little bit of what I've heard also from my colleagues, I think there's a very strong need for us to humanize the experience of suicide, suicidal thoughts, suicidal attempts, and what I mean by that is you know, to make a very conscious effort for us to look at the not only the humans who are involved in themselves in the struggle of and the distress and the people around them, and you know, and to embed you know, a culture of, you know, compassion and also just some very basic human ingredients. I think connection and hope are indispensable, we know, in human for human life. And you know, I think we talked a little bit about you know, how this topic of suicide and deaths of despair, I think, move us specifically, you know, invite this conversation about maybe some of the challenges of over medicalizing all of this, and I think that you know, being able to have conversations and connect with other human beings, I think is fundamental.
And there's been a shift, sorry, Jason, just quickly, to have individuals with their own lived experience of suicidal experiences, and certainly loss survivors, which has longstanding been a very important voice. But now voices of lived experience and loss can inform so much about everything we're talking about, how we structure a research, you know, project, how we think about policy, and that lived experience, the family members, individuals, which by the way, turns out to be 55% by our research at AFSP of the population. So we're not talking about a minority group who has experienced this at some angle or part of the experience related to suicide.
Yeah. Actually, what I was going to, I don't think you have any more questions. So I was something along that lines, which is memoirs. I mean, addiction memoirs are just probably one of the greatest portals to me into understanding what the phenomena is. And just to bring the whole brain thing back into it, to me, it shows the impoverishment of that construction. I mean, just how enormously complex it is, and how deeply human. And so to the extent that, you know, we can promote those things, I know we love to read, and a lot of people really, frankly, don't. So to the extent that people then do it more in a verbal, you know, format, but that's really important. Talk about humanizing. You know, I
think just one of the questions that I just had for you guys, but one quick point is, I think in the sort of popular culture, we kind of highlight different TV series or films, and are really worried, and there's some hand-wringing over their portrayal of suicide or addiction. I'd like to get to a point where addiction, or maybe a suicide attempt, or a mental health crisis is just kind of woven into the person's history as if it's normal, everyday thing, not on a special event. I was struck in a TV series. It was a British TV series where the person got buprenorphine at the emergency room, and they didn't make a big case of it. It was just, that's what they got. And we don't really have that here, but it would be cool if we did. But I'm wondering if you guys can speak to, just for journalists out there in the audience, what advice you have in terms of covering deaths of despair, covering addiction, and covering mental health, covering suicide, and covering alcoholism.
Well, can I go? I'll go first. I would say that my biggest bit of advice is to beware of the, you know, the recurring narrative. And that's difficult because sometimes the recurring narrative is the right one, but sometimes it's not. And I mean, I can elaborate if anyone wants to get in touch with me afterwards and send them some stuff I wrote, but very briefly, I mean, one recurring narrative in the opioid crisis, or at least the early, what's called the first phase, which was dominated by prescription pills, is this concept of the accidental addict. I'm paraphrasing someone here, frankly, someone who used well, lots of drugs, but she's the one who, I've quoted her at length, better for her to say this than me, which is, that is just, that's just misleading. Most people do not go to the doctor with a toothache, come away with some Percocet, and I'll stipulate they probably came away with too much Percocet. No one needed a month's worth. They probably needed 3 days. Fine, all that is true. But you don't do that and then your life unravels unless there are co-occurring factors or a person has had a previous problem with addiction. And this accidental addict narrative, which is, someone was a cheerleader, everything was great in their lives, and then it all went downhill, and then a month later they were selling their body for heroin. I mean, this is very rare, and I think it's a narrative that actually serves a rhetorical purpose. And when you keep hearing it over and over again, call me. I mean, just, I think really people's Rolodexes get kind of small, and they go to people who give good quotes or the ones who promote themselves very well. And, these things are often subtle, and just so basically just have a detector out for a story that keeps coming over and over again and doesn't comport with the facts. And on this one, Jason, not going to take up our time with it now. I have a ton of citations to easily send folks showing that the average person who abuses and gets addicted to prescription pills is not the patients for whom they're prescribed. And to the extent that patients do become addicted, they're folks with pre-existing vulnerabilities that, granted, doctors must be much more attentive to when they set out to prescribe.
Christine?
Well, yes. I mean, Sally, that was so helpful to just crystallize it that way. And around the issue of suicide, I would say there are some similar recurring sort of narratives that really serve to perpetuate a myth and to keep us in really a state of denial that we can't ever learn how to prevent suicide, detect risk. And I'm not saying that it will ever be easy or perfect, because there will always be shame that causes people to zip up and keep it cloaked. So we won't always see everything, but that narrative for suicide, I think, really used to be very strongly. I think journalists have learned to move away from this in large part, but it was a one cause effect model, that something happened and out of the blue, the person suddenly and precipitously takes their life, which is, of course, unfortunately, that is the way it feels to many people. If you've lost somebody, you know this, but it's not consistent with the science, where there are lots of changes that are happening. And again, no one is to blame for not noting those, because we just have not gotten to that point yet. But I think the other part that is even more, in a way, dangerous in the short term are reporting on, let's say, deaths of despair or suicide, where there are no solutions, no science, no prevention strategies mentioned as part of the sort of doom and gloom picture. They really should always be paired together in that sort of public health framework that does not, it's not reductionistic, but where there actually are messages of hope and the role that really anyone can play, let alone a policymaker or a health system leader. And the last thing is around the fact that, unfortunately, suicide contagion is a real phenomenon. And so I think, again, most journalists are very well aware of avoiding graphic portrayals, sensationalized stories where it's often to the sunset with an easy, beautiful ending, and that it was a rational choice, or something like those can be dangerous for people who are currently at risk of suicide and are exposed to that. And that's true for reporting. That's also true for entertainment content.
Oscar?
Yeah, I mean, I'm just going to maybe come back to a couple of things that we mentioned at the beginning. One is that I think in covering this phenomenon or concept of deaths of despair, I think it's important that that it be nuanced with the understanding of how it affects different communities, including different racial and ethnic groups and age groups. Because I think, like we said, we've tended to maybe tunnel vision or attention towards one particular age group and race, ethnicity, and education. So I think that's one. I also believe very strongly that it's really important to also report on promising practices and solutions to address the very factors that are addressed. And I think that the concept of deaths of despair is helpful to understand maybe some of what's actually happening. But I wish that we could also shift our conversation to how do we build hope and how do we repair, how do we build community to strengthen the protective factors that are really natural to human existence. We're really only talking about supporting communities, individuals, and families to rebuild what we've always had, families, friends, social organizations, civic organizations, and places of worship, etc., where people actually have found hope and a meaning and purpose, like one of the people in the audience was asking about.
I would just, as this is a journalist, I'll give my little quick 2 cents. One is when you're interviewing somebody who has gone through a suicidal crisis, be patient with them. They may not tell you their whole story at first. That's why there's second interviews. That's why there's third interviews. Sit with them and be patient. Don't talk. I have a very hard time not talking, but sometimes I will write above my computer, don't talk, or on my hand, shut up, or something, so I can just listen to the person. I think the big thing is to be patient and to not, really read the person when they're talking about a trauma and it's uncomfortable. Give them a break. There's one other point I would quickly make is just I'd interviewed a woman and we really ended up in a tough place. It was really a tough interview and we ended in a sad, we were really talking about some really difficult things. And I was like, okay, I'll see you later. When I talked to her, the next time she's like, hey man, you kind of left me in a ditch, here, you can go about your life, but I'm kind of like thinking about my problems and the stuff. Can you try to end on like a joke or so like, let's steer the conversation back to something else that like gets me out of that place. So we would make it a habit of just sort of being more informal at the end and sort of joking around and sort of having a better time of it. I would tell her some dumb story about how, I did something stupid or whatever, which happens all the time. The other thing I would say is just in terms of which as Sally brought up, I'll just piggyback on it a little bit. In reading any study, make sure to read the study thoroughly. And if you don't understand something, you really need to contact the people that wrote the study and check everything with them, because oftentimes reporters, we're not great scientists. That's why we became reporters. And so you want to make sure that I don't understand statistics at all. Unfortunately, it's really a hindrance to this stuff, but you really want to call up the researcher and say, hey, what does this really mean? Explain it to me in layman terms so I get it. You don't want to kind of pass on bad information based on your misreading of the studies. And then we have one question here that's left. And this person is mad because she thinks that I wasn't going to ask the question. I was too scary, but I think it's a great question and a provocative one. Why have suicide prevention when we're all going to die anyway? And who wants to be sick and old and suffering? Don't worry, I don't want to kill myself. But she raises a great point here, which is, what's the purpose? And, is there an end? Maybe we don't want to be old and sick or in chronic pain.
Well, I'll start with a very just basic thing that I am in a fortunate position of knowing a lot of people who have survived their own suicide attempts. And while in the short term, not everyone is happy about surviving because they're still in that place of suffering and despair. But in the longer term, and actually some of my colleagues have told me that the moment they, whatever it was, jumped or had a sort of different perspective on their life and their future. So, yes, we're all going to die, but even beyond saving lives to suicide, it is really about a movement and a science and a community response that allows people to live their lives as in their true selves as human beings, whatever that is, their sense of connection, purpose, meaning, hope, wellness. So to me, it's more about that.
Yeah, and thank you. And when Anne or Laura mentions pain, one of the consequences of our collective response to overprescribing opioids, which was a true phenomenon, and there's a history of that, but there's no question they have been overprescribed within the last, well, it peaked in 2011, but from the 90s until about then, is the response to that was, I would say, an overly harsh and indiscriminating crackdown on prescribing. And that has hit chronic pain patients the most. And in fact, I have some colleagues who are keeping a registry of folks who died in the context of not being able to get adequate pain medication. So, some suicides are I suppose, really are quite planned, especially if one is old. I think the euthanasia debate is a very legitimate one to have. But to the extent that there are modifiable variables that are contributing to someone's not wanting to live, then it is intolerable to overlook that.
Yeah, agree.
That's good. Who cares about suicide prevention, right?
Yeah, it's a good question, and I'm glad it's being asked, because it kind of goes to the core of why this matters, why this work matters, and I have a couple thoughts. One is that I'm part of a center that focuses on, among other things, on the cultural views or the cultural formulation of whatever people are going through. And it's conceivable that someone's cultural formulation around wanting to die could be one where someone feels like, this is something that I've evaluated my options on. This is something that doesn't feel like an experience of pain and distress, and I have evaluated, what this means to me, and I'm making this decision for myself. Certainly, we know historically there are some cultures that are more, have not necessarily experienced suicide in that manner. But what I think we do know is that in the culture that we live in, the experience of suicide usually comes with immense pain, psychic pain, and it's not this very rational decision for many people. There's this interesting and somewhat disturbing approach in economics that talks about the trying to understand suicide from this perspective of utility maximization. This idea that at the point at which someone's life, someone evaluates that their benefit of being alive is going to be less than dying, they will make this rational decision. And, I respect that. And that's certainly maybe the case for some people. But I do know, and also from personal experience, that is actually not the experience of probably the majority of people. The people that are thinking or act in those thoughts or attempts, and probably most likely the majority of people who actually die have not gone through this very rational process. And in that way, I see suicide prevention, especially because of the discussion we've had about the economic injustices, that it is part of the set of factors that increase the risk for suicide, and that's psychiatric pain, the psychic pain that people live in. The work of suicide prevention is also part of an issue of social justice and economic justice. And I think that was the heading of our panel series, justice in mental health, and that is probably what it means to many people, because people typically don't want to be in psychic pain, and because of their circumstances. So I think that is the context in which probably matters. And at the same time, you know, in this conversation of cultural differences, you know, it is conceivable that it would mean something very different for some people, and that needs to be taken into account as well.
Thank you. I think we're running out of questions, and it might be time to wrap up. I want to just add that my limited research on the topic, it does seem like suicidal thoughts are fleeting thoughts, and oftentimes therapists will tell somebody in despair, just get through this moment. You might just, if you can't, say, if you can't feel like you're going to get through the next hour, how about the next minute? How about the next 30 seconds, and go from there? And it usually works. I think that's sort of important to realize, is that like that sort of level of heightened despair and extreme suicidality is a peak. There's valleys. There's a way to diminish those things, and there's simple skills that you can use and techniques, and we just gotta share them and give people, as I think we've come across, integration and hope are some key factors there. Giving people hope and integrating systems. So thank you guys so much for the panel. Awesome conversation. You can send me critical comments about my moderation over email. All right, I'll see you guys later.
Thank you.
Thanks,
Thanks, guys.
everyone.
Thank you, Jason.
Thank you so
everyone.
much, everyone. Bye-bye.